I really want to congratulate John and Cyril for having brought together the world leaders, the three world leaders whose trials have shaped the way that we think today. So certainly in so many areas of diabetes and cardiovascular disease. So without any further ado, let me introduce Dr. Hertzel Gerstein. Hertzel is probably one of the University of Toronto's greatest alumni in the present era, and so it's a pleasure to introduce him as the person who has, I think, put Canada on the map for leading trials in diabetes and cardiovascular disease, with an immense experience and for one so young.
Lovely. I'm going to take you home, David. That's superb. Thank you very much for that lovely introduction. It's very nice to be here. I see some familiar faces from many years ago, and I grew up and went to university here, as David said, so it's great to be here. And so I'm going to be speaking on this topic as why we need large, pragmatic outcomes trials of nutritional interventions. There haven't been a lot of them. There's one that we're going to hear about later on this morning, but I think we need them. We need more of them, and I'm going to hopefully convince you as to why we need to have these large trials. This is a list of the companies that I'm happy to have worked with to help improve the lives of my patients with diabetes by developing drugs and therapies for them. This is, there's none of those actually are one of them actually was one of the sponsors here. And everything I'm going to say is based on the evidence from trials and from the methodologic literature. And this is very much going to be a methodology discussion and to really impress of what the strength is of trials. And one of the important reasons for me to talk about this and for me to give this sort of presentation is to counter a very disturbing trend, which I see now a lot and which some of you may notice, and that is the trend for people to state that with all of the, quote, big data, unquote, that we now have available at our disposal, all of the administrative databases, all of the randomly collected Facebook and tweeting and Twitter and all the other stuff that's out there, all the ISIS-type registries and UKGP registries, we really have so much data that we no longer need to do large randomized controlled trials. The answer is just in our databases. We just have to get a fancy programmer and a couple of statisticians, and we have the answer to life and the universe and everything else we might want to do. And I'm going to show you that that is actual nonsense and is extremely dangerous and will kill people. And so that is the point of this whole presentation. So first of all, what is an outcome? I talk about the importance of doing outcomes trials in people with diabetes and in people with other conditions as well. What is an outcome? Well, I'll tell you what an outcome is not. An outcome is not a glucose level, a blood pressure level, an HSCRP, or a level of, or the response to an oral glucose tolerance test, or a glucose. Those are not outcome levels. Those are things that are interesting readouts for scientists who are doing research. An outcome is something that's important to your mother, your father, and the New York Times, and your boyfriend, girlfriend, husband, wife, etc. So, outcomes in people with diabetes are listed on the slide. So these are the things that afflict patients with diabetes that are serious, and you don't have to be a doctor or a healthcare provider to appreciate that any of the things on the slide are important. So blindness, cataracts, kidney failure, nerve damage, pain, ulcerations, heart failure, stroke, cirrhosis, dementia, cancers, all of these things are more frequent in people with diabetes than in people without diabetes, or they occur more earlier in people with diabetes and people without diabetes. So in my world of diabetes and outcomes trials, these are the things that we're trying to mitigate, prevent, reduce, delay, etc. So when we're talking about outcomes trials with nutritional interventions, we're talking about nutritional interventions that affect these things, not necessarily affect your glycemic response or other things. That may be a mechanism, but that's not the outcome. What we're interested in preventing, reducing, delaying. What are risk factors for these outcomes? Well, outcomes occur, and we say, well, why did somebody die? Why did they have a heart attack? Why did they have a stroke? So we need to do research to understand what increases the likelihood of these things from happening and from not happening. And I'll show you in a minute that some types of research are excellent for identifying risk factors for these outcomes. And on the slide is a list of the risk factors for, this is not exhaustive. There are many things missing from this slide. But this is a list of a number of important risk factors. All of these are shown to influence and predict a higher incidence or an earlier development of all the outcomes that I led earlier on. And different ones are for different outcomes, obviously, but age is the best risk factor for anything. Age is a risk factor for death. Age, the older you are, the more likely you're to die, right? Diabetes duration is a surrogate for age, but it is also in and of itself a risk factor. Dysglycemia, meaning an elevated glucose level, that is a risk factor for almost all of the outcomes on the previous slide. So, and I'm not going to show that data, but the higher the glucose, the higher the risk, and whether or not you have diabetes. If you have diabetes, the higher the glucose in diabetic patients, the higher the risk. Your insulin levels is a risk factor as well. People with a higher insulin level have a higher risk of outcomes. And I'll come back to that, etc. I'm not going to go through all this list, except to point out one other very important one from a public health perspective. There's absolutely no question that smoking is a risk factor for many, many bad outcomes. But a prior outcome, the biggest risk factor for anything is having had it before. So the biggest risk factor for stroke is a previous stroke. A fracture is a previous fracture. Not only that, the biggest risk factor, a big risk factor for an outcome is a different outcome. So if you have had lots of myocardial infarctions, you're at higher risk of fractures, for instance, than if you've never had a myocardial infarction, because there's comorbidity that goes back and forth. Now, some of these outcomes are potentially modifiable. Some of these risk factors, are potentially modifiable. And a lot of outcomes research, a lot of trials, and diet is not on this slide, but should have been, I guess, for this presentation. But diet is modifiable as well. And a lot of trials are looking at modifying something that we think is related to the outcome, seeing if we are reducing, delaying, or preventing the outcome. So, why do we need to do these trials? Why can the big data that I alluded to already not answer the questions for us? After all, there are terabytes of data just floating around all over the place. Not just the National Security Agency, but many other people have this data. And why can't it be analyzed to give us these answers? So really, the way to flip this around, the question is, what can big data do really well? And what can big data not do? So big data, which means anything except a controlled randomized trial. So big data includes epidemiologic studies. It includes administrative databases, anything except a large controlled outcomes trial. Big data can really nicely identify risk factors. And what is a risk factor? A risk factor is any measurement that you make that in its presence, the outcome is more likely to occur or earlier to occur than in its absence. For instance, blue eyes are a risk factor for malignant melanoma. So people with blue eyes are more likely to have malignant melanoma, to develop malignant melanoma in the future than people without blue eyes. So anything, risk factor tells you nothing about cause. It tells you nothing about mechanism. It's simply a measurement of any sort that is associated with a higher likelihood or earlier likelihood of an outcome. And big data is wonderful at identifying risk factors. It's perfect. It's the best way to do it. You do a large study, you find things are related to each other. But are the risk factors culprits? Do blue eyes cause malignant melanoma in the skin? That is the question that big data is hopeless. In fact, cannot answer the question with very rare circumstances, with very rare exceptions. And so the reason it can't answer the question, because even though there is a relationship between that risk factor and that outcome, you don't know if that relationship goes directly from the risk factor for the outcome or if it goes through something else. Because in the example I just gave you, for instance, Blue eyes is just something that's related with fair skin. Fair skin's related with likelihood propensity to sunburn. Propensity to sunburn may be related to malignant melanoma. So anything you measure, that risk factor, may simply be linked to something which is itself the causal factor, or which is linked to other causal factors. And that thing could be a gene, it could be a protein, it could be a dietary component, or it could be a toxin, a process, a drug, a behavior, it could be an environmental exposure, it could be all sorts of things. And of course, that could be linked to something else, could be linked to something else. And that is, the methodologic term for that is a confounder. A confounder is just a variable, another measurement, which is linked to both the risk factor that you know about and the outcome that you're interested in understanding. That's all that the word means. And so the clever people in the room always say, well, great, you're telling me what I learned in first year, medical school about confounders. We know how to deal with that because as smart statisticians, we can make all sorts of adjustments and we can take account of the confounders and deal with them, and then we can discern whether the risk factor, in fact, is causally or important related to the outcome, and therefore whether modifying it will reduce the outcome. And my answer is yes, you can certainly account for and adjust for every confounder, assuming that A, you suspect it as a confounder, and B, that you've measured it, and C, that you measured it well. Because confounders are not just the ones you know about. Confounders can be measured, so you might have measured the color of the skin in addition to the color of the eyes, but they may have been unmeasured. You might say, geez, I wish we measured the skin color in that study, or you may not have even thought about it. And in fact, I can tell you that there are probably close to an infinite number of confounders, and we as humans can only measure or think about maybe 100, maybe 50. So there are always confounders you don't know about. It is impossible to adjust for the confounders. If, for instance, hip circumference is an important determinant of whether or not obesity is related to cardiovascular outcomes, and you haven't measured hip circumference and you just waist circumference, then you have a problem looking at abdominal obesity. And if you haven't measured waist circumference, it's an even bigger problem. That is the issue with this, and therefore, big data can deceive you. So if that's true, if you haven't measured, and you can't adjust for them all and you won't know it, how do you solve the problem? So how do you solve the problem is you change the slide. So what does randomization do? Randomization is a way to solve the problem. Now, why? Now, there's a caveat here. Randomization is only a useful way to solve the problem if the sample size is big enough, okay? So everything I'm saying is assuming a big sample size. If I toss a coin 10 times and I get 8 heads, nobody's going to flinch. If I toss a coin 800 times and I get 700 heads, you're going to think the coin's rigged, okay? So randomization is only useful with enough people, and in fact, with enough outcomes. So you need to have a big enough study, not just to have enough people in it, but you need to have to really be confident, 1,000 outcomes that you have to measure. That's why many of the big RCTs have 10,000 people in it. So you need enough people in it, and that's a very important principle. So if the sample size is large enough, what do you do when you randomize people in light of what I just said? So here's what you're not doing. You're not randomizing the treatment to one group or the other. That's not the way to think about it. The purpose of randomization is you're randomizing every single one of the measured, unmeasured, and unimagined confounders. So you start with a group of 10,000 people, and you divide them into 2 groups with 5,000 people that on average each group has the exact same number and identity of confounders on average as the other group. So even the confounders you haven't thought about, you don't have to do any adjustments or anything because the 2 groups now are identical with respect to all the confounders. And then once you randomize the confounders by the randomization process, you just arbitrarily choose to give the treatment to one group and the control to the other group, because they're identical groups. So it randomizes the confounders. It randomly distributes all of the measured, unmeasured, and unimagined confounders to create 2 or more identical groups one of which is given therapy while the others get a different therapy. And that's the whole point of randomization. Now, there are little additionals to this. Why do we talk about being an intention to treat analysis, which means you have to analyze every person randomized to group A and every person randomized to group B, regardless of whether they took the drug, or regardless of whether they took the dietary intervention, or regardless, because if you don't analyze everybody, or as close to everybody as you can who was randomized, you're then selectively choosing groups that have more confounders or different confounders in one group than in the other one. And so the other thing people say, well, yeah, but it doesn't really tell you exactly what the thing is doing. But an outcomes trial is a pragmatic approach to therapy. The question you answer by a good outcomes trial with an intention to treat analysis is not if I give you the drug and if you take it every day and do everything I told you, what are you going to happen down the line? It's if I prescribe this drug or this therapy or this diet to you, will the patient be more or less likely to have the outcome I'm interested in than if I don't prescribe this? So and that's the question that intention to treat studies do. It's an intention. My intention is you take this intervention, and then in the end, are you going to be better off if that's what I discuss with you? And I put all the supports in place for adherence, etc. But my intention does not depend on you totally adhering to what I say to you do as a physician or as a public health person or as an economist. And obviously, we'd love to do blinded trials because then we're totally positive that nobody is changing the random distribution of confounders by activities that are adding other confounders. With nutritional trials, you can't do blinded ones, so you miss that. But on the other hand, when you get an outcome from a nutritional trial or an open trial of any sort, the answer is, okay, if I randomize you to this intervention plus all the behaviors you're going to do as a result of you knowing that you're getting this intervention, are you going to be better off than the other ones? And that's also legitimacy as well. So I'm going to give you some examples to show you why outcomes trials are important and why big data is misleading or can be misleading. But while I just want to remember to say one other thing, is that big data can sometimes tell you about cause and therapy in one exception. And that is when the effect size is big. Okay? So we need to do randomized controlled trials when we're looking at 50% reductions, say 80% reductions, etc. When we're looking at 500% reductions or increases, it's probably pretty obvious. You don't need to do an RCT, right? I know if I jump out of a plane, I'm going to die. I don't need to randomize people to jumping or not jumping out of a plane to know I'm going to die. If a person's got a gangrenous leg and you cut it off and the person lives, you don't have to do too many trials of gangrenous legs, et cetera, or in the 40s penicillin to cure pneumonia, right? Because the effect size is huge. But most of the stuff in chronic disease nutrition, we're talking about effect sizes 1.5, 0.8, 0.7, 0.6, not 4, 5, or 0.1, right? So that's why I'm saying what this meant. Now, what are we learning from outcomes trials? Well, here are the risk factors. Let me just spend a couple of minutes giving some examples. Dysglycemia is clearly something I won't spend a lot of time with. I'm not going to talk about more versus less intense glucose lowering. But one of the things that comes out is, are the trials of glucose lowering due to the glucose lowering, which is, by the way, confounded with the drugs that we use to lower glucose levels? So I'm going to talk about the drugs that we use to lower glucose levels. And this is the class. There are about 12 classes of drugs available to lower glucose levels in the world. And I'm not going to go through every one of them because there's no time to do this. But what I will do is just focus on two for which there's really good evidence. Let's talk about insulin first. So insulin is a Canadian, fantastic, a Canadian story. It's a Canadian legend. In 1922, just down the road on College Street, the first injection of insulin was given, and it changed the history of medical therapy forever. But since the day insulin was used to treat a person with type 1 diabetes, there has been huge controversies of insulin's benefit for type 2 diabetes. And in fact, if you do big data analyses, epidemiologic analysis, you will find that people who are prescribed insulin have a lifespan about equal to serious cancer. That, you have about a 3 to 6 year lifespan in people who've got, and in fact, insulin by every administrative database you will look at, or every big data, kills you. It is a bad therapy. Insulin, you should never go on insulin because giving insulin is associated, there's a strong link between insulin and subsequent death, subsequent amputations, heart attacks, strokes, you name it, insulin is related to it. And there has been a debate for 80, 90, 100 years, that, since actually it's now 94 years, or 95 years, that insulin should not be used to treat type 2 diabetes because it kills them from all of the big data. So how do you solve the problem? You do a randomized controlled trial, and we did the randomized controlled trial, where we randomized people who didn't need to go on insulin, but they were randomized, they were early in their course of diabetes, to 1 injection of insulin, 12,500 people, 1 injection of insulin versus no insulin. Followed for 7 years. They had a lot of other risk factors for heart attacks, strokes, and deaths, so they had lots of those events, and in the end, here's the effect of insulin on all the bad outcomes that were measured. So the left group was insulin harm you, the right side of the line, insulin helps you. The event rate for MI stroke or cardiovascular death was 3% per year in both groups. Insulin has a totally neutral effect when it's tested in a randomized controlled trial, insulin versus no insulin on MI stroke, heart attacks, deaths, hospitalization for heart failure, cancers, you name it. Insulin does not cause any of those things. Why then do all the big data say that? And this says that? Well, if you're a doctor who sees patients with diabetes, you'll know that how is insulin being managed in the last 80 years? Insulin is being withheld as a last-ditch therapy when nothing else works. So the story would be the patient is in the hospital with a terminal illness, the priest walks out of the room, and the resident walks in and writes the first prescription for insulin. And it's no wonder. It's no wonder that the administrative data. But if you don't know that, if you're an epidemiologist, you just, you should never prescribe insulin. You're going to get on CNN, and you're going to tell the world that anybody who prescribes insulin is doing experiments on patients and is killing them. And, when we were starting this trial, we were told that too, right? So you need to sort of have skepticism and test it objectively. So this is a good example. Here's the other example, DPP-4 inhibitors. This is a wonder class of drugs. Well, it actually is very interesting because they use a gut hormone, and a lot of this research came out of work done by Dan Drucker here in Toronto. And these are drugs that increase the levels of GLP-1, glucagon-like peptide, which is an important gut hormone. And there's been a lot of question as to what are the effects of these on cardiovascular events. So some guy in Italy, who everybody knows, Dr. Manami, who will meta-analyze anything that moves if they're walking across the street. So he did this meta-analysis of all the DPP-4 inhibitor trials. And what does he show when you meta-analyze them to see what is the effect on cardiovascular events? Each of these trials had about 100 or 200 people, maybe 400. They were all not done for cardiovascular disease. They were 6 months long to 12 months long. They were done to look at the effect of these drugs on glucose lowering. They collected cardiovascular events as adverse events. And my God, this drug is a wonderful drug. It reduces the risk of heart attacks and strokes by 31% according to this meta-analysis of small little trials. So they were all randomized, but they were randomized with small numbers for different reasons and not designed in a way to assess cardiovascular events. When you then take this and you subject it to a proper, well-done, randomized outcomes trial, you see that the effect on cardiovascular events is total unity, no effect whatsoever. And this is now there are 3 of these trials that have all shown the same thing, no effect whatsoever. 2 examples of why big data is an issue. And so if modern medicine today relied on big data, and databases, there's many examples where the big data has gotten it wrong. So, the Women's Health Initiative, which is a randomized controlled trial showing that estrogen therapy to postmenopausal women is maybe not that good an idea, was accused of being unethical to be done because, of course, you can't deprive women who are 55-year-old of estrogen because it keeps them young and youthful and sexy and everything else, but, and it prevents brain disease, it prevents dementia, and it prevents cancers. Why? Because people who are in a higher economic status would be more likely to take estrogen replacement therapy. Perhaps. There's other reasons. But the trial shows that it was not a beneficial effect. An important example. The cardiologist used to suppress extra beats all the time because that was a predictor, it was a risk factor for death. Well, the randomized controlled trials showing that when you suppress these extra beats, you actually do not reduce death. You may even increase the risk of death. And there's many other examples. Here's the best one, and some people in the room will remember in the 60s and 70s, the NIH thought, you know, men get more heart disease than women. So, and you know, the big data at that time suggested, well, maybe we should give men estrogen because, you know, and that was a trial done. It was the coronary drug project, and it was stopped early because of harm. So, you know, you can be deceived by epidemiology. When you do randomization, you know, there's no mechanisms at all. All you're doing is you're just saying, let's observe what happens. And so you have high bias with epidemiologic data, and if you do lots of meta-analyses of small little trials, each trial has so much noise back and forth that you really don't know what's going to happen, and that a lot of random error. And then last example is insulin level. If you measure the insulin level in the blood, I mean, you all measure insulin level and all the nutritional things. If you measure the insulin level in the blood, people with higher insulin levels in the blood have more heart attacks, strokes, bad things. Therefore, insulin in the blood must kill you. Well, is that true? So there was a randomized controlled trial, and there's many things that cause insulin to go up in the blood, including weight and many other things, and maybe it's not the insulin in the blood. Well, so there was a randomized controlled trial, NIH funded, of people with proven coronary artery disease. They all were candidates for revascularization. They all needed a coronary bypass or an angiogram with a percutaneous intervention. And they were randomized to glucose lowering, they all had diabetes, glucose lowering with drugs that reduce insulin levels in the blood, and glucose lowering with drugs that increase insulin levels in the blood, with the goal to get the same glucose level in both groups. So one group got, you know, glitazones and metformin, the other group got insulin and sulfonylureas, and in the end, what is the effect of lowering the insulin level on cardiovascular events in these high-risk patients? Zippo, no effect whatsoever. So another example of the epidemiology and the big data telling you one thing. When you actually do the trial, you say, wait a second, it's not what we were told by the big data. So I'm just going to summarize now. And I really, you know, in my summary, I think I want to sort of, before that, say, whenever I give a talk like this, I always have a question that somebody says, well, sure, that's very true, et cetera, but we can't do clinical trials or outcomes trials to test every nutritional intervention and to test every medical intervention in our patients. So, you know, we have to use big data, and we have to use observational studies and everything else. And the answer to that is, of course, there is truth to that statement. And as I said, when the effect size is huge, it's not part of this discussion. But we can't have a trial to answer every question. How do you deal with that? And, you know, I think to answer that, I could have put this quote together. I'm quoting myself, but I can tell you that I have to acknowledge, you know, everything I've said, and my whole career really would not have happened had it not been for David Sackett, who died about 3 weeks ago. And Dave Sackett, many of you know, was the father of epidemiology and clinical trials. He came from McMaster, well, in the States originally, to McMaster. And so everything I say in this slide especially is inspired by him, and I really think it's appropriate to acknowledge him in a talk like this, in a day like this. But how do you deal with the fact that we don't have a trial to answer every question? Well, I think here's the quote. The trials that we do have can be thought of as they comprise islands of evidence, and these islands are linked by shorter and longer bridges of extrapolation, and they span oceans of uncertainty. The longer the bridge, and the farther we are from an island, the shakier the extrapolation. More good outcomes trials and outcomes research means more islands, shorter bridges, and less uncertainty. But there will always be an ocean to span and a bridge to cross. And so the point is that we can never replace the whole ocean with islands. But we can certainly get more and more evidence so that we're more confident and when we're extrapolating from one that we really have an evidence base upon which to build the care that we do to our patients or the public health recommendations that we make. And the very last slide is carefully done outcomes trials are indispensable, I think, and they reliably provide unbiased estimates of treatment effect. And the proof of that statement is, to a scientist, is that the results surprise us. If we are never surprised by our research, we're not doing good research. Research means we should not always know the answer before we do the study. Thank you very much for your attention.
It's now a great pleasure to turn to invite Dr. Ed Horton. Ed is another old friend of mine, young friend of mine, from days when we were on the American Diabetes Association's Nutrition Committee. He strayed from that path and went off, finally being the director of diabetes at the Joslin Center at Harvard, where he currently is chair, a professor of medicine. Obviously, Ed has tremendous experience, although he in the whole lifestyle factor as a sort of skiing Olympian from the past, who then went heavily into medicine and landed up on the nutrition committee of ADA. So it's a great pleasure to have Ed back to talk about another of the great trials that have shaping the way our thinking and where we need more guidance, which is the look ahead. So Ed, welcome. Thank you.
Well, thank you very much, David, and good morning, everyone. It still is morning, I noticed. So this has been a terrific Congress. I've learned a great deal. It's been wonderful for me to see some old friends and have just a chance informally to talk about things. And so I really want to thank all the organizing committee for putting together such a terrific program. I want to thank Hertzel for his talk because he set this up perfectly. I mean, I cannot think of a better introduction to talk about the LookAHEAD trial than what Hertzel has told us this morning. My disclosures, I have been told that my travel here from Boston, I'll get some support for that, so I appreciate that very much. I do have relationships with several companies, either as an advisory board member or consulting member, and I have received a few speakers fees from companies over the years, but none of them really interact with what I'm going to talk about today. The LookAHEAD trial is supported by the National Institutes of Health. It's a large multi-center trial involving 16 centers scattered around the United States. And it really is looking at lifestyle interventions, and most of my conflicts would be with the pharmaceutical industry. And I wanted to point out that the medical care in the LookAHEAD trial was not provided by us as the investigators. It was provided by the primary care doctors of the individual physicians. So they were actually the ones who were taking care of the diabetes management and all of the other comorbidities, the lipids, the blood pressure, and so forth. So we really did not, the only actual, we did have an algorithm for adjusting insulin doses in the intensive lifestyle group when we were putting them on caloric restriction and increasing their physical activity. So we did have an algorithm for that, and our staff in the studies actually implemented that algorithm, but everything else was really left up to their family physicians. We've heard a lot at this meeting about this, what people are calling the dual epidemic, and I thought I'd just review some of the recent data in the U.S. 65% of adult Americans, 2/3 of adult Americans are overweight, as measured by a body mass index of greater than 25, and 1/3 are obese with a BMI of greater than 30. So there's really no question that we have an epidemic of obesity going on in the U.S. Current numbers estimated about 26 million. I think it's now up to 29 million or slightly higher, or about more than 11% of adults with diabetes. But 79 to, I think the latest figure I saw was 85 million people with prediabetes, either impaired fasting glucose or impaired glucose tolerance. And the lifetime risk of developing diabetes in the 15-year-old kids running around now is estimated to be as high as 33% for men and close to 40% for women. So there's no question that we're just really trying to deal with this epidemic. And we all know from our discussions that in this population, cardiovascular disease is the leading cause of mortality. This, I think, is gotten our attention over the last several years. I know when I started out in diabetes, we were really focusing just on diabetic control and trying to reduce risk of the microvascular complications. But now, I think most of us are really turning our attention to the very, very high risk for cardiovascular disease. So I wanted to then tell you, bring you up to date on where we stand with the LookAHEAD trial. And 15 to 20 years ago, when we were planning this trial, there were many studies that showed that improved glucose control in people with both type 1 and type 2 diabetes reduced the risk for microvascular complications. But we really did not have solid data that good glucose control could decrease the risk for cardiovascular disease events. And we were just beginning to learn about that, and we were learning about the interactions between glucose, lipids, blood pressure, and so forth in this population. So we decided to really design a trial to look at whether cardiovascular morbidity and mortality in people with type 2 diabetes could be reduced through an intensive lifestyle intervention aimed at producing and maintaining weight loss. That was the primary goal. And now this program was a combination of both dietary restriction and increased physical activity, and I'll just show you that. But the primary outcome for the LookAHEAD trial was to look at the incidence rate of the first post-randomization of occurrence of a composite outcome. And this included cardiovascular death, either fatal myocardial infarction or stroke, a non-fatal MI, non-fatal stroke, or hospitalization for severe angina. We included that in this composite primary outcome. And we plan to follow people for 13 and a half years and randomize them into either an intensive lifestyle intervention program or a control group that we call the Diabetes Support and Education Group. And I'll describe these too. Now, we actually predefined a series of secondary outcomes, all related to the cardiovascular disease outcomes, and these were just the various subcomponents of the primary outcome. So here are the two groups: intensive lifestyle intervention, what we call ILI, and the diabetes support and education that we call DSE. The baseline characteristics of the participants, we had slightly more than 2,500 in each of the groups. They were 60% women. We tried to make it as representative of the U.S. population as we could, and we had 37% representing various ethnic and minority groups in the U.S. Average age, about close to 59 years, an older population. I didn't put it on this slide, but the average duration of diabetes, as best we could determine by history, was between 8 and 12 years of diabetes. So these are people who are older. They've had diabetes already for 8 to 10 to 12 years. So they're farther down the pike than the group that we were looking at in the diabetes prevention program and other studies looking at early intervention. On purpose, we limited the number of people that that we selected to about 15% taking insulin, and they were overweight or obese. The mean baseline body mass index was close to 36. average weight was just about 100 kilograms. So that makes it very convenient because percent weight loss is also kilogram weight loss, right? So you can go back percent and kilos very quickly here. And their waist circumference was increased, and they about 15% had a prior history, pre-existing history of coronary vascular disease. So we did the power analysis, and then this is back 15 years ago. Hertzel, you know, you're talking about the large N's we need. So what we did is we actually planned on a sample size of 5,000 participants in this study, and we thought we'd have an 80% probability of detecting an 18% difference in cardiovascular events between the two arms, assuming a p-value of 0.05. But a primary outcome rate of 2% per year. And we got that from reviewing all the literature on the current data on cardiovascular disease in our diabetic population and what the event rate would be. So we planned 2% per year, and we planned a follow-up of 13 and a half years. So that was the power calculation back in the late 1990s, okay? And I think this is important when I talk about the results. Okay, the lifestyle intervention phase, we divided into two initial phases. The first 6 months, we had weekly contact with the people in the ILI group. This was 3 group sessions a month and 1 individual counseling session a month. We set a personal weight loss goal of 10%, hoping that we would get a study-wide weight loss of 7%. And this was based on kind of the results from the lifestyle intervention that we had observed in the diabetes prevention program, which was actually just coming to fruition at that time. We basically reduced the calories, modest weight reduction, calorie reduction. At the time, we were thinking in terms of the American Heart Association and the ADA recommendations, reduce total fat in the diet to 30% or less, saturated fat in the range of 7 to 10% of calories. We did use some meal replacements during this initial phase to get people into the weight reduction program, gave them menu plans. And then for the physical activity, we asked them to gradually increase their physical activity to a total of at least 175 minutes a day of moderate intensity exercise, such as brisk walking or the equivalent. And we developed a program we called 10,000 Steps, which is walking about 5 miles a day. And so we really pushed the walking program as a major intervention here. Now, the second 6 months of the program, we backed off a little bit. We didn't see them quite so often. We had some telephone conversations with the patients. And for those who had not achieved their 10% weight loss, we asked them to continue to lose weight. But if they'd made the 10% goal, we asked them to at least maintain that weight loss during that period. Now, for the control group, we actually just had meetings with them 3 to 4 times a year as a group meeting and gave them some general talks about diabetes and diabetes management and so forth. We talked about diet, exercise, social support, but this was not an active intervention. This was primarily to keep them enrolled in the study. So it was not an active intervention, but we did see them to keep contact with them and encourage them. So here's the 1-year weight loss results. We were really thrilled. We got an average of 8.6% weight reduction in the intensive lifestyle intervention group, and really no significant change in the control group. So we said, hey, wow, this really works. We were able to achieve the weight loss program. Now, I'm not going to show you much of the 1-year data. Just here's the impact on glucose control. The hemoglobin A1C dropped by a little over 0.6%, which would be enough to get it approved as a drug by the FDA, just barely. But we did get improvement in A1C. Fasting glucose dropped by 21.5 milligram per deciliter. And we saw a close to an 8% reduction in their anti-diabetic medications. So the improvement in glycemia was associated with actually a decrease in the need for taking mostly oral agents, but it was also a significant reduction in the insulin doses in those who had been taking insulin. So we saw major improvements here. Now, I'm not going to show you the data, but we also saw improvement in both systolic and diastolic blood pressure with less use of antihypertensive medication, and we saw a decrease in triglycerides and an increase in HDL cholesterol, but no change in the LDL cholesterol during this first year. But what I'm going to do is now fast forward to the 10-year results. And I think many of you have probably seen these. They've been published during the last year or so. But here are the weight changes. And I want to point out two things. We got in the intensive lifestyle group the maximum weight loss at the end of 1 year, but you can see there was some regain of weight during the next 2, 3, 4 years, and then it flattened off and then has begun to drift down again. But still, we have about a 5%, 4 to 5% weight loss compared to their baseline during the entire 10 years of the study. But look at what happened to the control group. We had actually predicted, and I heard somebody mention this yesterday, that the control group was actually going to stay the same or gain weight, but they came down, okay, too. So we're seeing the control group actually showing some improvement of weight, but there's still a statistically significant difference in the weight between the two groups. Here's the A1C, okay? Yeah, the A1C is kind of crept back up again, and we're not able to maintain that tremendous improvement in A1C. It's still statistically significantly better than the control group, but still nothing really, in my opinion, to write home about. Here are the blood pressure changes. Look at the systolic and diastolic pressures, which dropped very dramatically. The diastolic has stayed down, but the systolic has begun to come back up again. But again, look what's happened to the control group. We've seen improvement in both systolic and diastolic pressures in the control group. And that is associated with more use of antihypertensive medications in this group. Here are the HDL and triglyceride results. The HDL went up nicely in the group, but look what happened in the control group. It's gone up too. And the triglycerides have come down very dramatically in both groups. So we've seen improvement in the lipid profiles in both groups, both the control group and the lifestyle group. And actually, LDL cholesterol came down more in the control group than it did in the lifestyle group because there was greater use of statins and other dyslipidemic drugs. So I think you're beginning to get the message now. You know, there's two ways to deal with all of these risk factors for cardiovascular disease. You can take more medication, which we're seeing as general trends in our population, and our control group was getting all the messages. You know, they were seeing their doctors. They were being started on blood pressure medications, statins, et cetera, and I think some of them were increasing their exercise some too. And there's no question that there was a group. So here are the differences. The ILA had better weight loss throughout the trial. They had greater improvements in their physical fitness. I didn't show you those data, but they did. They did very well. They actually exceeded our 175 minutes a week goal. I think it was 215 minutes a week was average during that first year. But they've slacked off on that too over time. They reduced their glycated hemoglobin and their need for insulin. That was very positive results. They did have sustained improvements in systolic blood pressure and HDL cholesterol, but they had the less improvement in the LDL cholesterol, but they used fewer statins to get there. So, okay, the question is, did the ILI reduce cardiovascular morbidity and mortality? That was our primary outcome variable that we are interested in. This was the analysis of the time to the first post-randomization occurrence of the primary and secondary outcomes in the two groups. Here are the results. No difference. No difference at all. okay? You can see that the DSE and the ILI group basically had the same rate of cardiovascular events during the course of this study. And then if you subdivide the groups, looking at those who did not have any cardiovascular disease or event history prior, shown on the left, or those who did, again, there was no significant difference in the two subgroups. Obviously, those with a prior history of cardiovascular disease had higher rates than those without. And we did subgroup analysis, and nothing stands out here. There's really no really significant factors, no gender differences, no race or ethnicity differences in the results in this study. So the primary study question was answered. There was no significant difference between the ILI and the DSE in the number of heart disease events. That is, both groups had a similar number of cardiovascular events, and the main study question answer was negative. Both groups had a very low number of heart disease events. Both groups had less than half of the expected rates. And I think this is a very important factor. I mean, this is good news for all. You know, we just saw a general drop in cardiovascular event rates below what we predicted. It was less than half of what we had predicted back 15 or 20 years ago. And so the question is, well, why did this occur? Many participants are taking medications for their diabetes, high blood pressure, and high lipids, more so in the control group than the ILI. These medications combined with regular checkups with a health professional may have kept the CVD rates low in both groups. The results parallel the overall improvements in cardiovascular disease that we're seeing in the United States in recent years. I mean, this is a general trend downwards. I think the other question that I want to pose, and Hertzel, you may want to comment this, the people who actually signed up for this study, are they truly representative of the general population? And I don't think they are, because everybody that I talked to who actually volunteered for this study wanted to be in the intensive lifestyle group. They were a little bit disappointed when they got randomized to the control group. So I think this is probably, this study, I'm a great believer in randomized controlled trials, but the people that volunteer for randomized controlled trials also have other motivations. They tend to be more motivated. They've stuck it out. I mean, we've had over 90% long-term follow-up in both groups. So that is another one of your confounding factors that you might want to add to your slide there. When people sign up for a randomized controlled trial, you know, are they really representative of the general population? Now, I consider this to be a very positive study. Some people, you know, the press got hold of this and said the results were negative. I'm not going to have time to show you. We've just published results that the ILI group has a significant decrease in the development of severe renal disease. I'm currently analyzing the results on neuropathy. We don't have it totally analyzed yet. We've analyzing some of the results on retinopathy. So we are just analyzing the results on the microvascular complications. But we have published just recently, Bill Knoller was the first author on the paper, the results of decrease in severe kidney dysfunction. The other thing that one of my patients brought this up, put this on the top of your list, obstructive sleep apnea. I threw away my CPAP. You know, I went on this program and I can sleep at night. I don't have my CPAP, a tremendous improvement in that, and I will show you one slide on that. But now we're looking at the impact on malignancies. One of the hot areas is cognitive impairment and increased risk for Alzheimer's. We have studies going on in that area. We're doing brain MRIs and functional MRI testing in subsets of the population. Just the problems of aging with diabetes, mobility, falls, physical function, and the multiple other problems. This gives us an opportunity with a very dedicated and loyal population of people with more advanced diabetes, further down the pathway of diabetes and its complications, that we can hopefully answer some of these questions as we continue to follow this population over time. I just want to show you only one slide. This is a slide showing the total remission of obstructive sleep apnea at year 4. And look at this. The ILI group, 20%. Had remission of obstructive sleep apnea, and it was only about 3 or 4% in the control group. So I look at this as a very positive study. I'm a great fan of randomized control trials, and I think we're going to learn a lot from continuing to follow this group of people. So with that, I'll conclude. Thank you very much.
It's now a very great pleasure also to finally introduce Dr. Jordi Salas, another great friend who entertained many of us at Stressa, many of us at RES at his own base, and Jordi is the lead investigator of the new Predimed study and one of the lead investigators of the last Predimed study. So he will tell us, I think, some tremendous news, and I think we've probably shown most of his slides during the course of the last 2 years. I think everyone has shown most of his slides. So he doesn't really have to put many slides up. He just has to talk to us. Thank you, Jordi.
Thank you very much for your introduction. Good morning, everybody. It's a shame, but today is my last day here in Toronto. I have a flight in approximately 3 hours, but I would like to publicly express first, again, my gratitude today to all the organizers, and especially for this excellent and friendly symposium, especially to John and Cyril and David. I have really enjoyed these beautiful days, and especially these nice and interesting discussions. And I have learned a lot of all of you. Thank you very much. I would like to talk today about the Predimed Plus study. 2 days ago, I showed you the results of the Predimed 1, and this is an ongoing project related to the LookAHEAD. So it's fantastic, this introduction made by Dr. Horton. Here you can see my disclosures of commercial support. My institution has received research funding from the INC, who is supporting this program, and I am also non-paid member of the scientific committee of this International Drug Free Foundation. Here you can see other disclosures. But the Predimed Plus sponsors had no role in the design and conduct of the study. This study has founded by the agency, the National Agency of Health in Spain. And also we have the nuts and the olive oil for giving for free to the participants. But the companies that give these products had no role in the design of the study, the collection, management, analysis, interpretation of the data. What is the rationale of the Predimed Plus study? The rationale is that no study has never demonstrated that weight loss and maintenance using a hypocaloric diet and physical activity promotion reduces the risk of cardiovascular disease and mortality in individuals with overweight or obesity. So the objective of the Predimed Plus trial is to evaluate the effect of an intensive intervention on lifestyle based in an energy-restricted Mediterranean diet, physical activity promotion, and behavioral therapy in order to lose weight, to maintain this weight, and in order to demonstrate the beneficial effects of this intensive intervention on the primary prevention of cardiovascular disease. We have only one trial that has addressed this question, is the LookAHEAD. But the LookAHEAD has been conducted on diabetic individuals, more than 5,000, with overweight. They have observed differences in changes in body weight after 10 years of follow-up, as has been shown by Dr. Horton. But this study has stopped in September 2012 because of futility. After 9.6 years of follow-up, no differences in cardiovascular incidence and mortality have been observed after this follow-up. There are many explanations, probably, of this futility. Why the LookAHEAD failed to find differences in cardiovascular disease and mortality? This is an important publication conducted by Jean-Pierre Desprez and published in Nature Review Cardiology. And he has several questions on the current paradigms in preventive cardiology raised by the LookAHEAD. For example, do patients with type 2 diabetes need to do more physical activity and exercise in order to reduce the risk of cardiovascular disease than individuals without diabetes? Or another question that I think is an important question is, should we focus on caloric restriction or put more emphasis on improving nutritional quality? In case of the LookAHEAD, they use as a diet a low-fat diet. And we think that low-fat diet is not the best approach for preventing cardiovascular disease, as we have shown on the Predimed trial. Mediterranean diet for weight loss. As you know, there are several strategies that have been tested in order to lose weight, especially the strategies changing the macronutrient content of the diet. For example, a low-fat diet, a hyperproteic diet, a low-carbohydrate diet. But we think that probably the type of fat, the quality of fat, the origin of fat, in this case, the vegetable origin with phytosterols, with phytochemicals, etc., the type of fat or the quality of carbohydrate or the origin of proteins, of animal origin, of vegetable origin, are more important than the amount of the macronutrient. For example, here you can see several strategies. The low-fat diets. The low-fat diet have demonstrated that have a decreased long-term adherence and relapse, are low in vegetable fats, vegetable oils, so probably this conduct to a reduction in the consumption of vegetables. Or we have evidence of failure. For example, the LookAHEAD or the Women's Health Initiative Dietary Modification Trial. In case of the low carbohydrate diets, it has been demonstrated beneficial effects on blood pressure, on fasting plasma glucose, in lipid profile, but these improvements were lost after 12 months of follow-up. Usually, low carbohydrate diets are rich in saturated fatty acids, so increase LDL cholesterol. So it is a major factor, a major cardiovascular risk factor, increasing the risk probably of atherosclerosis, and are low in several healthy nutrients such as fiber, calcium, magnesium, potassium, several nutrients that are very important and are related also to cardiovascular risk. So another possibility is, another approach is to use a traditional Mediterranean diet. A traditional Mediterranean diet is rich in vegetable fat from olive oil and tree nuts, high in unprocessed vegetable food, vegetables, fruits, legumes, low consumption of meat and meat products, moderate consumption of fish and wine, and rich in phytosterols with low glycemic load, and healthy in terms of cardiovascular prevention, but because we have demonstrated a 30% reduction in the incidence of new cases of cardiovascular disease and mortality in the Predimed trial. Do the Mediterranean diet increases the risk of weight gain and obesity? We have evidence that come from epidemiological prospective studies. Here you can see, in general, several studies, several prospective studies, some of them large studies, showing that Mediterranean diet adherence is inversely associated with weight gain, with waist circumference gain, or obesity risk. So this could be a good approach for testing. And also we have a clinical trial. This clinical trial that has been conducted by Iris Shai and in collaboration with May Stanford from Harvard. In this study, the direct trial, in this trial, it had been randomized 322 individuals and test the beneficial effects of the Mediterranean diet on weight loss and maintenance. Here you can see the results of this diet study in terms of weight loss. Here you can see the low-fat diet, the Mediterranean diet intervention, and the low-carbohydrate diet intervention. And as you can see, the Mediterranean diet and the low-carbohydrate diets are effective alternatives to the low-fat in comparison, in relation to the weight loss and especially maintenance. But in case of the Mediterranean diet, it has been observed more favorable effects on glycemic control. So, what do we know? We know that the Mediterranean diet has passed the test of long-term sustainability, nutritional quality, and effectiveness in terms of cardiovascular prevention. So the hypothesis is that a low-calorie Mediterranean diet might be the most sensible approach for weight loss and prevention of cardiovascular disease. We have published this letter just at the end, when it has been published, the LookAHEAD. So here you can see the design of this Predimed Plus study. In the Predimed 1 study, we have compared a low-fat diet to the advice to follow an unrestricted Mediterranean diet. Now we go to another step, is to compare the same unrestricted Mediterranean diet that we have used in the first Predimed trial to another intervention with a Mediterranean diet, energy-restricted Mediterranean diet with physical activity promotion and behavioral intervention in order to lose weight, to maintain this weight on time, and probably this could be related to a decrease of cardiovascular. We have, for this, we have calculated the sample with the data, previous data of the Predimed trial, and we need, for this trial, 6,000 individuals. Here you can see the eligibility criteria, men and women between 55 and 75 years, with a body mass index between 27 and 40 kilograms per meter square, and meeting 3 or more criteria of metabolic syndrome. Only 25% of the population will have diabetes. We have limited this in order to be different from the LookAHEAD. And we randomize now the population to the usual care using the same recommendations that you give to the participants in the Predimed 1 and to the others to an intensive weight loss lifestyle intervention with a restricted Mediterranean diet. Here you can see the recruiting centers, 22 recruiting centers in Spain. In red, you can see the recruiter centers of the Predimed 1 trial. And in green, you can see the new recruiting centers in the Predimed Plus study. The primary endpoint of the Predimed Plus study is a compendium of myocardial infarction, non-fatal stroke, or cardiovascular mortality, but also weight loss and long-term weight loss maintenance and weight circumference changes. Here you can see the secondary endpoints, all related especially to body weight and weight loss, total mortality, stroke, myocardial infarction, quality of life, heart failure, atrial fibrillation, peripheral artery disease, type 2 diabetes and its complications, different types of cancer, neurodegenerative disorders, depression, osteoporotic fractures, cholecystectomy, cataracts, gout. And also here, several intermediate outcomes, for example, nutrient intake, blood pressure, lipid profile, fasting glucose, kidney function, the medication needs, C-reactive protein, implicated hemoglobin, liver function, cognitive function, depression scores, etc. This study has started in November 2013. I planned to finish in July 2016, the recruitment. Participants are recruited by medical doctors from primary care centers associated to the recruiting centers, and physicians involved in the recruitment will be the responsible of the medical care of the participants, but we have another team, the Predimed Plus team, that are composed by dietitians and nurses that give the intervention to the participants. Here you can see the recruitment just 1 month before. Now we have recruited 1,800 participants, and we expect to finish the recruitment at July 2016. We have planned a running period, but also in order to assess the candidate willingness to participate in the study and predict the compliance with intensive intervention of 4-week periods. And we have planned 2 years of recruitment, 6 years of intervention, and 2 years of follow-up. Here you can see the intervention protocol after the run-in period, randomization to both groups, usual care or intensive lifestyle intervention with Mediterranean diet, restricted Mediterranean diet, exercise, and behavioral treatment. We have planned during the first 2 years several contacts for the intensive lifestyle intervention, 3 contacts every month, 1 individual contact, 1 groupal session, and phone contacts also. And in case of the usual care, we have only contacts at baseline and every 6 months and yearly during the follow-up. The group sessions with no more than 25 participants. And here you can see the data collected. We collect data especially at baseline at 6 months and yearly during the follow-up, several data, physical activity data in relation, for example, with accelerometers, blood samples, several samples, urine samples, several questionnaires of cognitive function, quality of life, etc., etc., etc. How the intervention is implemented. We recommend to the intensive intervention group, we recommend an energy-restricted Mediterranean diet pattern, aiming to reduce energy by 600 kilocalories per day, approximately 30% of energy requirements, increase the overall quality of life, promoting the consumption of minimal processed foods, increasing the consumption of typical Mediterranean diet food, and refrain from elements of the Western pattern. We give for free to all the participants 1 liter of extra virgin olive oil per month and 500 grams of mixed nuts. we use a tool in order to negotiate the goals with the participants in order to scale in a 17 score, as we have used in the Predimed 1 trial. We have used a 40-point score measuring the adherence to the Mediterranean diet. And we have changed this 14 score because now is an energy-restricted Mediterranean diet, and we use several changes in this score. This is the 40 point was validated, and this need to be validated. But in this case, we have a 70-item screener in order to change the overall food pattern of the individuals. We planned a specific intervention on physical activity with a gradual increase in physical activity, especially brisk walking or equivalent, and a specific behavioral intervention with stimulus control, problem-solving skills, and relapse management, and the implementation of several self-monitoring tools, for example, weight self-monitoring every 2 weeks, physical activity with pedometers, and this 17-item questionnaire. Here you can see in case of the control group, minimal intervention by the dietitians with the same recommendations that we give for the Predimed 1, with total energy intake ad libitum, no specific recommendations on physical activity, no weight, and physical activity self-monitoring, and no aims to lose weight. We give also the same amount of virgin olive oil and nuts in this group. For us, is a tool in order to have more adherence to the intervention. And also this screener is just to collect information of the participants. So no instructions on how to lose weight. If participants wish to lose weight, they can contact with the primary care physicians or other health professionals for counsel on weight reduction strategies in case of the control group. Here you can see the steering committee, Ramon Struck and Emilio Ros from Hospital Clínico, Miguel Ángel Martínez from the University of Navarra, Dolores Corella from the University of Valencia, and Dr. Fito from the IMIM in Barcelona. And here you can see the data safety monitoring board to ensure the smooth running of the trial and the safety of the participants. That is chaired by Mayor Stanford, but also other members are Joan Sabater, Arne Astrup from Copenhagen, Francisco Fernandez Avilés, and Javier Pissunyer from Columbia University. I take the advantage to acknowledge my group of research, my human nutrition unit in the Faculty of Medicine of Rovira i Virgili University that is located in Reus. That is a city 100 kilometers south of Barcelona, and the principal Predimed investigators. Here you can see the first Predimed investigators, the Predimed 1, but also there are other now new Predimed principal investigators that need to be there, but are not in this slide. Thank you very much.
Simon, would you start the questions, please?
Okay, well, am I only allowed to ask one question, or can I ask a couple?
Well, we'll see how good the first question is.
Okay, so between the two of us, if that was the case, let me ask Dr. Horton about the LookAHEAD study. So after the results, obviously it's a beautifully done study. It's a lot of work, a lot of resources devoted to it. But is the result really can be used to answer the original hypothesis that you designed the trial for?
Well, this is really a very good question. And I think that to me, the way I just personally look at it, the lifestyle program was very effective in keeping the rate of cardiovascular events low. The control group also decreased their event rate very significantly, so there was no difference between the two groups. But they were actually getting medications. They were so their lipids were better controlled. They're more statin use, more blood pressure control. So I think that, to me, it just shows there's more than one pathway to get there. It doesn't mean that the lifestyle program was ineffective. It means that you can. I think we're generally much more aware now, in our general population, but also our diabetic population, of the importance of really treating all the risk factors for cardiovascular disease aggressively and early. The other point I get across from this, I've been involved in the diabetes prevention program as well, and I think that the other lesson I learned from this is you have to start early. You know, I think we should be identifying people at high risk for diabetes, people with metabolic syndrome, and that's where we have the greatest opportunity to really impact on the long-term outcomes. Because the patients in the LookAHEAD trial were really much farther down the pathway. They're older. They were 59 years old. They're now you know, in their late 60s or early 70s, and I think we're just starting too late. I mean, we know that the whole process for cardiovascular disease starts very early, even before diabetes. So, two messages. One is there's more than one way to skin a cat, but if we're going to skin the cat, we better get it early when it's just a kitten.
I think Michael wants to make a comment.
Yeah, I mean, I represent the cardiovascular community. We've spent most of our time focusing on these patients with very advanced coronary disease and looking at forms of revascularization that may be optimal. And I would echo what Dr. Horton says, that in these patients, the effects of blood pressure lowering, glycemic control, LDL even, are different than they are in patients who are younger. So there's it's a heterogeneous population. So I think the duration of diabetes and the degree of advancement of coronary disease are playing a role here, so that maybe these interventions of lifestyle are more suited to the pre-diabetic patient or the patients who are younger diabetics.
Simon, the first one was pretty good, so you get a second.
All right, so very good answer, Dr. Horton, but what I was trying to get at is actually trying to challenge all of us to think about the different paradigms of therapeutic randomized trial from a pharmaceutical paradigm of thinking versus the thinking of nutritional or dietary intervention trial. Like based on the Predimed study, as well as the other successful study. I've been involved in the Women's Health Initiative, and over the 20-some years of the trial, we know how difficult it is to do those trials. You are essentially changing people's sort of like complete way of life, so to speak. And then compliance is a major issue. So in the name of a randomized control intervention trial, but what you're getting in practice, it is a observational study. It is almost. So that's one thing. The way the thinking in terms of thinking along the line of using one particular drug for the participant to accept it or not, it is very different from a way of life to sort of one have to engage in.
Yeah, well, yes, you're bringing up a very important point, and Hertzel, I'm sure, wants to make a comment on this too, because we have used randomized controlled trials as kind of the gold standard for our trials, and we do this in the pharmaceutical industry. You know, it's clear, but when it gets into lifestyle modifications, that's why I made the comment. It was just my own personal comment, and nobody else that I've talked to in our group has really talked about this before, is how do you take the results of a randomized controlled trial and translate it to the general population? And that's what, you know, I mean, the Women's Health Study is perfect, and the Physician's Health Study. You know, I talk with Joanne quite frequently about all this. I mean, we need those kinds of data too. I mean, that's real life, right? So randomized controlled trials, while they're scientifically important, can't necessarily be translated totally to real life. I don't know, what do you want to say?
So I'm going to have a slightly different spin on this, okay? So first of all, it's important to remember that a randomized controlled trial is a prospective study, and you can analyze the results from a randomized controlled trial as if it were an observational study if you ignore the randomization. So you still have a cohort of X number of people that have been followed X period of time. And so it's wonderful. So you can use the findings you get in a randomized controlled trial in order to do all sorts of hypothesis generating and test a whole bunch of ideas and do all sorts of really interesting analysis that will drive other good research down the line. However, randomized controlled trials are crucial. You cannot, and if you don't get the result that you expect to find, it doesn't mean that the randomized controlled trial is wrong, and it doesn't mean that you need to explain away the randomized controlled trial. So, like with respect to my friend Ed here, you can't argue it both ways. You can't say, look, the DPP shows that you can prevent diabetes with diet and exercise, therefore we all have to do diet and exercise, but the LookAHEAD show doesn't show it, therefore we should still all do diet and exercise. No, in fact, the DPP shows that diet and exercise in a randomized controlled trial is strong, really strong evidence that modest modifications to your lifestyle will prevent diabetes. What the LookAHEAD trial shows is that you have and the DPP trial also had a group of very motivated people. So in the LookAHEAD trial, if you have a group of motivated people, an aggressive lifestyle intervention is not going to reduce your cardiovascular event rate differently than usual approaches in the United States and Canada and some European countries of aggressive intervention on risk factors and lipids and blood pressures and everything else. I think the inference is that, and I think a fair inference from LookAHEAD is you can do it with lifestyle or you can do it with drugs. With respect to cardiovascular events, you're going to get the same finding. That is, and that I think is a perfectly good interpretation of the randomized controlled trial. What Ed also talked about is that there were other outcomes measured that were not pre-specified as primary outcomes, but they were pre-specified as outcomes of interest, other outcomes. One thing, for instance, was diabetes remission. 11% of people in the LookAHEAD trial went into diabetes. These are well-established diabetes. Their diabetes went away. And in fact, even at 1 year and even at 4 years, 4% of those people still had their diabetes went away versus a lot lower in the control group. That, in fact, is an example of there's reduced exposure to dysglycemia. That may very well, that plus the lower A1C may very well explain the renal effect. Now, if this was a drug study for FDA, you could not say we've proved it because the primary outcome was not significant, and therefore you could say that all the other analyses are hypothesis generating. Great. Research is not a yes or no answer. You know, a randomized controlled trial is just an experiment, except it's a really expensive experiment. And the trouble is, if it was a bunch of mice, you can do it 20 times, and you can replicate it, and you can do it. In humans, you can do it 2 times, 3 times, 4 times, but it doesn't mean you don't learn from it. You know, and so I think we actually are agreeing with each other very much. But I would say it's not to, you don't dismiss or you don't say that the methodology is bad because you don't like the results. I mean, the results are the results, and you go forward and say, what can we learn from this to do other research?
What can we learn from it? Right. I agree.
Andreas, please.
Andreas Pfeiffer from Berlin in Germany. Ed, I have an interesting question to you. When we present the data from the LookAHEAD study, which is really a great study and very interesting, you still have 2 components in there. One is the food and one is the physical activity. And this funny graph there, kind of which stops after 4 years, is something from which I conclude that you cannot get people to do physical activity. You told us otherwise now. And the second point is, was the diet the wrong diet? But I think, is that conclusion correct? Why did you stop showing the physical activity data after 4 years? And did you really get a difference? Because what the cardiologists see, even in very advanced coronary disease, is actually if you put people to physical exercise, you can greatly reduce event rates even without further intervention. There are a couple of nice studies.
Yeah. Well, I think the physical activity component of it obviously is really important, and we do have questionnaire data, you know, that we've collected on the patients because it all is really self-report from questionnaires. I know we've got those data all the way out. I don't think they've been fully analyzed. In the early part of the study, we did an analysis to see if we could sort out how much of the impact was, could you explain, by weight reduction and how much of it by physical activity. And it came out that the strongest predictor was the weight loss. But to me, I'm a great believer in physical activity, as you probably know. And I think part of that is it's much easier to measure weight than it is physical activity. So the physical activity component, we didn't do VO2 maxes on, well, we did submaximal testing a couple of times, but we didn't do VO2. We did a VO2 max in the beginning, mostly as a safety issue. We wondered, because we actually did not randomize people if they couldn't meet certain criteria by doing a VO2 max. So the exercise component of it still needs to be analyzed in more detail. And you're right, the focus has been mostly on the weight side of the equation. But I think the exercise is very important.
No, but for me,
Sorry, Jordi. Don't, please.
Yes. For me, one of the problems is that the LookAHEAD has been focused on losing weight, and there are several types of possibilities of losing weight. I have talked about diet, but also physical activity needs to be rethinking. Because if you in the slide that you have the curve of weight loss, you can see that after 5 years, it has a decrease in the weight in both groups. Mm-hmm. What is the result of this? Is sarcopenia?
Well,
Perhaps the intervention induces sarcopenia. And losing weight is not good because of this. And probably there are other possible interventions that sarcopenia are prevented, will be prevented. What do you think about this?
No, I agree with you completely. We have a ton of data coming out of the LookAHEAD study, and I wasn't able to even scratch the surface in showing you things. But we do have sub-studies looking at body composition, and there's no question in this population, which was actually, they were 59 years old at randomization, and we're now 10 years, 12 years down, so they're 70 is the average age. Some people are older than that. And we are getting into the problems of aging in a diabetic population. And this study really now gives us the opportunity to look at some of the issues of aging. And the sarcopenia of aging is very, very important issue. David and I were talking about how much trouble we're having walking up the stairs now.
Oh no!
And so I have a personal interest in this. Once you get up into over the age of 80, you begin to realize that sarcopenia is a significant factor in your life.
Velimir, please.
Thank you, Jordi, really for a very nice project. I am from the Italian country. We are really looking for your results. But my question is: did you take also population from rural area? Because the participant, I think there will be a big difference between the citizen from city than some from rural. Because in rural area, especially in Mediterranean area, near the sea, these people know what is Mediterranean diet, they practice this diet, because there is really no problem with economic status of this patient. You could produce olive, produce the taking the fish yourself sometimes. Especially these people practice a lot of physical activity for daily job. I think later we will analyze this data. And very important, we made some subgroup for analyzing then the degree of physical activity, and also special, really they implemented this diet. If this some citizen who must pay everything. And
Yes.
also the problem for Canadian, how is implemented Mediterranean diet in Canadian, especially in United States, right?
We can test this, yes. Thank you very much.
No, I think Gabriele?
Gabriele Riccardi from Naples, Italy. I have a question for Jordi. There are two important features of science. One is generalizability, and the other one is reproducibility. Well, I often quote the Predimed study in my talks in Italy and elsewhere, but I always get the question from the audience, okay, but what the Mediterranean diet is? Now, you define Mediterranean diet on the basis of 17 parameters that you have in your... I think that is useful to interpret the data and to make the trial, but it is a bit difficult then to translate into clinical practice and say to the patient or to healthy people what they really should do. So my question is, on the basis of the first Predimed study, are you not able to identify within these 17 features 3 or 4 which really matter, which really make the difference between the control and the intervention group, so that in the Predimed Plus, you can concentrate mostly on these 4, 5 features which really make the difference? Because otherwise, we get the impression that, okay, the Mediterranean diet works, I know that it works, I appreciate the result, but then it becomes difficult to translate this for Canadian people or for people in China or for people elsewhere in the world.
Thank you very much for this interesting question. The generality is one of the limitations of the clinical trials in general, no? And this needs to be resolved with other studies, I suppose. I think these changes are easy to be implemented. In the Predimed 1 study, we have used as a tool a 40-point questionnaire with 40 items. And dietitians try to scale in these recommendations, in these 40 items. So if you measure in one individual the score, you have 9 points. The dietitians focus in the rest of the points in order to increase, to scale in the Mediterranean diet score. I think is an easy tool in order to increase the adherence to the Mediterranean diet in terms of public health problem, public health. I don't know. I think what are the changes responsible of the beneficial effects in terms of cardiovascular disease and mortality in the Predimed 1? It is very difficult to explore this. Probably is the reflect of little changes that we have conducted and we have arrived at. Because in this 40-point score, we have observed differences in changes between groups in 11 of these 14 points. So I think the results of in terms of the prevention of cardiovascular disease is that we have changed the overall food pattern, not a lot, but with several little changes, and also especially for the nuts that we give for free to the participants and the olive oil that we give for free to the participants. But nuts and olive oil probably are is a tool in order to increase the adherence, because people come to the consultation in order to have the olive oil and tree nuts. And in this occasion, the dietitian have time to change the overall food pattern. She has another occasion to change and to scale in this Mediterranean diet. So okay. I think at the end is the changing the food pattern, what is important in order to achieve and to have this reduction in the terms of cardiovascular disease and mortality.
Okay, we're going to have one last question from Jenny Brand-Miller. Short question and very short answer, please.
Okay, Jenny Brand-Miller, University of Sydney. My question is for Dr. Gerstein. I apologise if I haven't pronounced it correctly. Oh, that's good. I know you don't like metadata, so my question is, but you do like large randomised controlled trials, so my question is, would there be anything gained from combining all the data, say from LookAHEAD with Predimed, and teasing out what dietary factors, what nutritional patterns are associated with not only the best outcomes clinically, but the most enjoyment of food and life?
Yeah. So let me just make one comment. Actually, I don't dislike any research. All research is wonderful. It's just that what I object to is using a methodology which is not appropriate for making inferences about causality or about therapy for therapy, and then ascribing 100% confidence to that methodology and ignoring the appropriate methodology. So I object to misinterpreting the research. I mean, I think mice research is fantastic, but to do a mouse study and say you must do this in humans is an inappropriate interpretation of the mouse study. So I think what you've said is perfectly reasonable. But the point but it's not going to prove the answer. What it's going to do, if you were to do analyses of multiple trials that use nutritional interventions, not just the Predimed trial, but there are many trials where the outcome wasn't cardiovascular events, but were diabetes prevention. There are about 10 different diabetes prevention trials, about 12. Many of them use the nutritional interventions as part of them, and the Finnish trial, the American trial, the Indian trial, etc. And there's LookAHEAD, and there's other, and one needs to look at these results, not ignore them, look at them and say, what are we learning from them to help design the next trial? And the next trial, I mean, the Predimed people are doing that to design the second trial that they talked about. But I agree. Now, you're saying doing it in a systematic way, great. It's hard to do that, but I think if you can do that, it's really good too.
So you don't think you can combine them and say there were three groups, a control group, a low fat group?
I think that would be hypothesis generating at best. You could look at it, but you're not going to come to a definitive answer that would give you any confidence in recommending it at a global or a public health approach.
I think we better end the session now. I'd like to thank the speakers in the panel.
Good luck with your